Hi, I'm Candace Hilton, also known as Candy. I am the house manager for Grace House Akron, and today we're going to discuss our pain management at the end of life. Pain is a result of a person's emotional, spiritual, and physical response to an experience. This would be why two patients who may have a similar injury, they may not have the same pain because they may have a different experience. So their pain may be different. They may have different levels of pain. It may feel different to them. So there's no predictable relationship between the amount or the size of the injury and the feeling of the pain. So here are some myths that I think most of us have probably heard throughout life and throughout the course of taking care of people. Sometimes it's thought that pain is normal as you age, that that's just something that's going to happen to you as you get older. If you're older or you have a diagnosis of dementia, that you're less sensitive to pain. If you don't report pain, you probably are not having any. If you can sleep at night, you don't have pain. A lot of times people think that if someone is asleep that, oh, they must be okay. They're not having any pain whatsoever. If you use pain medications, you will get addicted to them. That's probably the number one myth. People, when they are especially like in hospice or palliative care, they think, well, if I take morphine, if I take oxycodone or OxyContin, then I'm going to get addicted to it. So these are not true statements, but these are things that kind of float around in the atmosphere that people think are true. So this is just some percentages. You can review that of pain and how it affects certain patients. 65 to 80% of patients with terminal cancer have pain. Nursing home residents, 71 to 83%. Experience pain, and 25 to 50% of the community dwelling elderly have pain, which limits their daily activity. There's different types of pain that we can all have. There's acute pain, chronic, nociceptive, neuropathic, and psychosocial. It's not just the physical, it's also the mental and emotional, like what the previous slide mentioned. Characteristics of acute pain, this is something that's more sudden, that comes on suddenly. It may last for a short amount of time. This says less than 3 months or as long as it takes for a normal healing process to occur. It can be more mild to severe pain. It decreases over time and goes away as the healing occurs. Can anybody give me an example of what they think an acute pain would be for someone? A headache. This is typically pain control with eventual elimination of the pain. And the cause can be identified with surgery, illness, or trauma. So if someone has surgery, they may have more pain initially, but then as their body starts to heal, it gets better and it goes away. So acute pain sign and symptoms. So things you would see when someone is in that acute pain stage is increased heart rate or pulse and respirations, increase in blood pressure. They may sweat, pale skin, anxiety, agitation, or confusion. So if you can get that with just an acute pain, can you imagine what it would be like for someone that might be having chronic pain that's consistently all the time? So which brings us to our next slide. What do you think would be in the category of chronic pain? Do you have any examples of what you think that would be?
I feel like neuropathy, maybe.
Back pain, neuropathy, yep. Very good. So this is more of a gradual, and it can be sudden onset, but it lasts longer than 3 months. So it might start out as more of an acute pain, but it could kind of gradually get worse and it becomes more chronic because it doesn't go away in a short amount of time. It could be an acute injury or event, but continues past the time expected for the healing to occur. This could be mild to severe. Sometimes the cause might not be known. The original cause may be different from the mechanism that maintains the chronic pain. So it could be different from what actually caused the pain to start, like it continuing to be pain for the person. So what are some characteristics of chronic pain? It typically does not go away. It might get better and improve over time. but it's intermittent. It goes up and down for the person. So some days may be really bad days for them with their pain levels, and then other days might not be so bad. The treatment is focused on pain control, so we may not be able to take the pain away, but to keep it controlled so that they're having, a good quality of life is the focus and the goal. Behavioral symptoms, little emotional expression or response. So the person might have a flat affect because they're dealing with this chronic pain all the time, day in and day out. It might be decreased physical activity, fatigue, feeling tired, or decreased social interaction. They just may not have the energy or the social connection of wanting to be around a lot of people because of how intense the pain might be. Nociceptive pain, it comes from tissues. So this is mostly like the bones, the joints, skin, muscles, and organ. So this is usually described as a dull or aching pain. Organ pain is usually a deep squeezing or crampy pain. So some examples, I don't know if any of you have ever had like a sprained ankle. That hurts so bad. And it's constant and throbbing, and it is a very dull, aching type pain. Gallstones, muscle aches, just in general, like especially if you work out after so long and you start getting the muscle aches, and arthritis. So those are examples of this type of pain. Neuropathic pain, which Kim, you mentioned that with neuropathy. This is when there's injury to the nerves or central nervous system, which consists of the brain or spinal cord. So usually people will describe this as like a burning or stabbing or radiating pain. Sometimes I've had patients say it feels like numbness and tingling almost, like when you know how we say our leg or foot fell asleep and you get all that numbness and tingling. I've had patients describe neuropathy like that's how it feels to them. So this can come from someone that may have shingles, especially diabetics, that the diabetes, when it gets so severe for patients, they'll get damage to those nerves and they'll feel the neuropathy in their hands and feet. And then people that have a stroke, this will be kind of an after effect for them as well. Refer pain, this is another type, and this is pain that's felt in the part of a body away from the area where the pain actually started. So examples of this, someone that complains of heart pain or angina, they always said, if you have pain in your jaw or your ear or the back of your arm, especially your left arm, that's an indication that it's something going on with your heart. So that's not where the pain started, but you can feel it in those other areas. So that's refer pain. People with gallbladder pain, they'll have pain in their shoulders. Liver pain can be felt in the neck or mid-back. So like our one resident that's here now, he complains of pain in his abdomen, but he also says it goes around to his back. So, and that's because of the liver condition that he has. Then we have psychosocial pain, spiritual pain, and suffering. And I think doing this type of care with hospice patients or residents, you see this a lot. I'm sure we've all taken care of patients that we say, it's not that you deny they're having physical pain, but you know that it could be something more spiritual, emotional that they're dealing with, and that causes them distress as well. So this is pain that comes from sadness and loss that can't be, and this can't be relieved with medication. I'm sure any one of us in this room have experienced the loss of a loved one or someone really close to us, and that is a pain that cannot be medicated. They always say the old saying, time heals wounds, and it doesn't take it away. It's just that it gets a little bit better for you over time. But that's something to recognize when you're caring for patients or residents. So how do we observe or know when someone is having pain? So do we all know vital signs? We don't really check them here. What are some things that we look at when we're looking at vital signs?
Pulse.
A pulse.
Respiration,
There's 4 of them. So you said pulse, respirations,
blood pressure.
blood pressure.
Temperature.
Yes, ma'am, temperature. So that's the 4 things that we look at consistently. We do check pulse ox as well, but most times it's for sure the 4, the temp, the heart rate, respirations, and blood pressure. So when it comes to pain, think about that as the 5th vital sign. And that way you're automatically knowing this is something to kind of assess or observe with the resident. So if it is something that they're having pain in that moment, you want to report that right away. If you observe it, or if the patient is actually able to verbalize it to you, you want to let the nurse or someone know. We would look at what the patient or resident already has had, if they have anything ordered for pain. If they don't, then we would need to call the hospice that they're on. But you would talk with someone, talk with the nurse about when to observe pain after medications are given. So some medications, you know, when you give them, it takes a little longer for them to take effect versus others. But you can find out how soon you would need to check back and see if it really did help, if it was effective or not. So when do you ask about pain? So I think it's really key here with the before and after personal care. That could be, I know a lot of the hospice agencies have their aides that come out. So we do that sometimes, but if you have to clean them up from being incontinent, just observe it if they can't verbalize it to you. Definitely before, during, and after the transfers and ambulation. And before you leave the room, just check and make sure, because they may not say anything to you, but just, hey, are you doing okay? Do you need anything for pain? Kind of observe and see while you're in there if you're noticing any signs of pain. And we're going to get into that, but just before we do, can you state some of the things that you possibly would see if someone was having pain and they weren't able to verbalize it?
Either facial expression.
Yes. There could be
Change in their breathing.
change in their breathing,
Tits up.
tense up, maybe some agitation, which could be in line with what Amber is saying with the tensing up, getting restless. Sometimes it is other things causing that, but if they're in pain, that could be an issue. Pain observation and reporting. So some important things for us to keep in mind is that you have to believe the patient's report of pain. I know we have all been guilty of it, but if the patient is reporting or the resident is reporting that they're having pain, then you just have to take that at face value and just, because pain is what their experience is. And even though we might not think that that's what it is, it's still what they're having. They're having that pain. Gather information from people who spend a lot of time with the resident. Pain may have different meaning to different families. So some people may have a very high tolerance for pain, and you think, oh my goodness, that person's got to be in pain, but they have a higher tolerance, or they may have a lot of things surrounding that they don't want to be medicated, and we have to respect that. Or they may want to be medicated a lot, frequently. We still have to respect that too. People may use different words to describe pain, achiness or sore, even though they may minimize it by saying, oh, I'm having a lot of achiness, or I may be sore somewhere, but it really in fact is pain. So things that you can ask the resident, where is the pain, how bad the pain is. And when you ask how bad the pain is, we use pain scales, and usually 0 is no pain, 10 is the worst pain. And you can say that to them. If you didn't have any pain, 0's no pain, 10 would be the worst. Where would you rate that? And this is broken it down to let you know what mild, moderate, or severe pain would be on that pain scale. What is the worst and least your pain has been in the past week? But I think just if for you all, if you really want to just get an idea of how bad their pain is, just asking them if they can rate it. And sometimes people will go past 10 there. It's 11, it's an 11 or a 12, you know that it's really severe because it's past that 10 mark for them. Here's just a picture of the scale showing you like none is 0 and mild is 1 to 3, 4 to 6 is moderate, and 7 to 10 is severe. Then this is helpful. A lot of times we would use this in the hospital for some people find it difficult to actually rate using the numbers, especially, little kids, but this can sometimes help showing them the pictures because then they can relate to it a little more and know where they fall in this category, if it's a little pain or a whole lot of pain. So they call this the Wong-Baker Faces Scale. So this is something, and I think we were planning on getting some of those tools for you to be able to have in the rooms if need be. The next thing is just going over the quality of pain. And when you're asking not only the rating of the pain, you want to think about the description of the pain. So some of the things like that's listed here, and you can kind of read that off, would be ways that a person could describe the pain. Stabbing, aching, crushing, pinching. So those are descriptive words, and I think that helps the providers know if they have an idea of how the person is describing the pain. It gives them a better idea of how it can be treated or managed, like which medications will help. So we got the rating, the description. Now, what makes the pain worse? Does it get worse when you're moving around, if you're tired, fatigued, if you're just laying there? Or what makes it better? Does medicine make it better, like the pain medicines? Doing activities, or it can be non-drug therapies like a massage. A lot of hospices will have massage therapy involved in the patient's care because that helps alleviate some of that pain. Those things could make it better and it not necessarily be medication. How does the pain affect the patient? Is it hard for that person to sleep at night? Does it affect their sleep? Is it hard for them to move, interact with others? Or does it make them feel sad, frightened, or anxious? Because having a lot of pain constantly all the time, it could lead to having those emotions. This would be important for us when our residents get to a point where they're considered actively dying, imminent. You don't have any way of getting them to verbalize if they're in pain. So we have to look at some of the things that we were talking about earlier with the grimacing and agitation that could be indications of pain. So some of the patients that this would include would be very young children, if a patient was in a coma, patients with advanced dementia, if they're confused or delirious, which we usually see that here. We get a lot of confused patients if they're near death or have brain disorders. So those are people that you might not be able to get them to verbalize if they're having pain. These are things that you can look at: the sounds, moaning, grunting, sighing, the grimacing, wincing, frowning. They may clench their teeth real tight. As I was saying earlier, they get agitated or restless. For some that may still be mobile and still can't verbalize, they may be rocking or pacing back and forth. Clenched fists or stiff arms, resisting care, pushing away, hitting or scratching. I don't know if any of you have, I think this just happened last week with one of our residents that was actively dying. It was hard to turn him anyways. It was getting more difficult to turn him in the bed, but it was almost like he was pushing up against. So it was hard to, get him to stay over. So that was a sign that maybe he was probably having some pain. Report these behaviors promptly because, again, this may be an indication of pain for a resident. So what are things that we can do to help when you've done these assessments or evaluations with the residents? What are things as a caregiver that you could do to help a resident that may be experiencing pain? So when we're observing and reporting the presence and characteristics of pain, that's all the information we just reviewed. So what's the pain rating? Is the resident able to rate the pain, the description of the pain, what makes it worse, what makes it better? What's the side effects of medications? So if they are taking something for pain at that point, is it effective for them or not? Or is it causing a whole host of other things? Like, is it causing nausea, vomiting? Is it causing more distress? Like, we have to look at that too. And then what's the patient and family goals for pain relief? Like, are they saying that they don't want the resident? I've had patients, families say, well, we want them to be comfortable, but we don't want them to be snowed where they're just like sleeping all day. So then it's kind of a fine balance as to how much we should medicate them and how much we shouldn't, so they can still be alert, but not completely like, sleeping all the time, day in and day out. Provide emotional and physical comfort to patient and families during the time of us trying to figure all the recipe, as I call it, the recipe for what's going to work best for them, because what works for one person or patient may not work for someone else as far as what's going to help their pain and manage it. When pain is poorly managed, it can lead to decreased quality of life, changes in sleep patterns or appetite, level of functioning. Person can become depressed, and it can change their mood and personality. Analgesics or pain medication. This is usually used in a step approach, and that starts with mild pain medications like Tylenol, and then they usually will work up to a narcotic such as morphine for moderate to more severe pain. And more than one type can be used at a time, but they usually will start low and slow. That's what I was always taught. Methods of administration. These are all the different ways, but we typically here will see the oral and sublingual. When I first started here, there was one resident that had the transdermal, so she had the fentanyl patch, but from what I'm told, they don't really use that type of method of medication administration too often. So, but these are different ways. We just don't use them all here. Tylenol, usually tried before other medications. That's usually mild or moderate pain, but it'll be combined with other medications. It's usually fewer side effects, and it takes about 30 to 60 minutes for that to work. So if you wanted to, like after you give it and you want to go back and check to see if it's helped the patient, you would go back within that time frame just to see if they're feeling effects from it. NSAIDs are non-steroidal anti-inflammatory drugs. So I'm sure all of us have taken ibuprofen, Motrin, Advil, or Aleve, naproxen, and this can be used for fever, pain, or inflammation. But one of the biggest side effects to be concerned about with or gastrointestinal bleeds. So if it's taken too much of it, for some residents, they may vomit blood, but that it's really severe cases of taking those types of medications, like all the time, consistently. So this type of medication or treatment is what we usually give here for our residents, the narcotics or opioids. So that's the codeine. We usually will give morphine. It'll be the MS-Contin, which is the longer acting morphine. So that's the one that's usually given twice a day, every 12 hours. And then the Roxanol is the liquid morphine that we use as needed for our residents. Oxycodone, You'll see Percocet. Percocet is Tylenol and oxycodone together. And then OxyContin is the longer acting one that usually is given every 12 hours or every 8 hours. Hydrocodone, Vicodin, and Hycodan. I haven't seen that one used very often. Back when I first started being a nurse, that was used all the time, but I don't see that very often. And then, of course, hydromorphone, Dilaudid, we have a lot of our residents on that as well. Fentanyl patch, again, we don't see that very often, at least not here. And then methadone, that is also a longer acting pain medication that they'll schedule every 12 hours or twice a day or 3 times a day. There's some that are short acting and some that are long acting. The shorter acting opioids are used PRN as needed for intermittent pain. And that's for patients that just started using opioids. But in our population, we'll use that because they have intermittent pain, and even though they may be on a long acting, they need something for breakthrough. So the longer acting is more useful and appropriate for those who have chronic pain or constant pain. So that's why they'll use the longer one, longer acting. So you all don't have to, like, you usually will just give what's in the pill box, and that's already in the pill box if the resident is on a longer acting pain medicine. So your responsibility is just to give what's in the pill box, but then you also can give something for breakthrough, which is the as needed, like liquid morphine or the Dilaudid or hydromorphone. So some things that are considered common side effects of opioids, drowsiness, respiratory depression. That would be if they were breathing less than 8 times per minute. But once it gets built up in their system, you don't really see that as a side effect. But the main thing, I think, is constipation, which is why most hospice agencies will order a medication like Senna or Miralax to kind of help keep their bowels regular so that they're not getting constipated or not getting severely constipated. But in addition to that, they'll encourage, as much fluids and physical activity or fiber that the resident can take. Other things you could see as side effects, nausea and vomiting, but that usually gets better after a few days of starting an opioid. Muscle twitching, and then the itching will be side effects. But then we've had some that are on Benadryl for that as well. So usually if it's side effects like that, they can order something else to kind of combat that, so it's not an issue. So adjuvants, these are medications that can be used in addition to the pain medicine that they're already on. So sometimes they'll use antidepressants such as like Elavil that might, in combination with their pain medication, will help be more effective so that it manages their pain even more. So the only thing with that, it may cause a dry mouth or difficulty urinating or increased drowsiness. Some will use corticosteroids or steroids. So you'll see prednisone or dexamethasone, which I think we have one resident now that is on dexamethasone, and that also can help so that the pain medicine is more effective. Some things that you may see with that: high blood pressure, increased blood sugar, because steroids can shoot your blood sugar level up. It could cause potential risk for infection or mood changes. Swelling, fragile skin, and bone weakness are other long-term side effects that you could see. They'll sometimes use gels, creams, patches, something like lidocaine. The lidocaine patches are usually so many hours on and so many hours off, usually 12 hours on, 12 hours off. Anti-seizure medications can be used for nerve pain, which is like the neuropathies. Tegretol, Neurontin is a big one, or the other name for that is gabapentin. That can cause side effects of drowsiness. What are some things, just as caregivers, like we may not be in situations or positions where you can immediately get like a medication change. If you notice that a resident is still having pain or distress, but you've given everything that they could have at that time, outside of contacting hospice, or you're waiting on hospice to come and evaluate the person, what are some things that we can do as caregivers that are non-medication or non-pharmacological methods? So non-medications that we could do to help try to alleviate some pain.
Or just stay in there and like talk to them and reassure them it's gonna be all right, or let them know you called hospice, we're waiting on the nurse.
I think all of that. How about music? You guys did this with the turning the soft music on in bed 5 recently. That was last week. If they're in a situation where they're awake and kind of alert and can interact with you, another thing that to help them, they call it guided imagery. Tell them to think of something that they really like or enjoy. Like my thing when I was pregnant and having my baby was to relax. I thought of being on the beach and the water, the sound of the water, and just that feeling of that being on the beach. So just helping them get a picture in their mind that may not take the pain away, but it can help them to kind of relax and not focus so much on that moment of being in pain. So there's a list of other things that you could do: heat cold application, distraction or relaxation can help them have controlled breathing, like breathe through your nose and let it out. Like when you take a deep breath in, act like you're smelling a flower, like to get the smell of that flower in your senses. So take it in, breathe out slowly. Like those types of things would be considered controlled breathing. Music, comfort foods. I don't know about that one though. I'm sure, but comfort foods, exercise or positioning, which you all do a good job of repositioning. Okay, so non-using drugs, and this is in continuation. You can ask the patient what they've tried in the past. I think sometimes we forget to do that. We can look on their history of things that they've done, but we don't really have that. In a hospital or doctor's office, that's something different, but include family or caregiver to get this information is very helpful. You can talk to a nurse, the hospice nurse, about what non-drug therapies to consider. Get instructions for specific strategies, because somebody with bone cancer, you wouldn't want to do a massage on them. Distraction, relaxation. So some of the same things that we already talked about, these can be effective ways to manage a person's pain. So barriers to effective pain management. How would you describe a barrier? What is a barrier? What's preventing effective pain management from occurring? So that's what this section is about. Sometimes with patient and families, they may not report pain to the staff to let us know it's even a situation, that they're having pain. It could be that they're concerned about distracting the physician from treating the disease, because they think if they're more focused on treating pain, that they're going to forget about actually treating the disease. I don't know that really happens so much here at Grace House with our residents, but probably in other environments it may. Fear of addiction and tolerance, which we probably all have heard that from patients and or family members, and concern about side effects. That's something that's a real concern for them, and maybe why they don't want to take any pain medicine. Major barriers would be healthcare providers, poor pain assessment and observation. So if that's not done properly, then how can you properly manage the pain? Concerns about addiction and tolerance and side effects. Fear of addiction. Do you think this is something that you've seen a lot since you've worked here? Patients and families having that fear that they'll get addicted to pain medications and kind of not want to take them? No? Okay. I've seen it in the hospital setting. Patient and families afraid it'll cause addiction. Opioid addiction is a chronic disease in which people have poor control over drug use and use a drug for reasons other than pain. They crave the drug. So addiction is very uncommon at life because it's not that. It's not opioid addiction. Fear of addiction is not a good reason to discourage use of opioids. It's a controlled environment that we're given the medications. So on the flip side of that, with the tolerance, this occurs when medications are used for weeks or months and patients need higher doses over time to get good pain relief. So their body kind of gets used to the drug and it's just not effective anymore. So a need to increase the drug usually results if the disease is getting worse. So sometimes you'll see that, which I think we'll see a lot of times, because it's like, oh, okay, this was helping for a long time, but now seems like it's not helping. The person is having more pain. And then that's when you know, okay, we may need to let hospice know so that they can reevaluate and see if this person should stay on this medication or be put on something different, or just adjust the doses of what they're already on. Some patients worry if they take strong painkillers early in the illness, they will not work later on, and that's typically not true. Tolerance does not equal addiction. So, I know recently someone had mentioned that one of our residents had started kind of what they felt was early on in his decline of taking morphine, the liquid morphine, and they were concerned if he's taking it now, it may not be effective later on. So just in summary, just know pain is one of the most common and most distressing symptoms at the end of life. And like we reviewed earlier, it's not just the physical pain. It can be the psychosocial, the emotional, spiritual pain that a person is dealing with. So keep that in mind when you're evaluating or giving care to a person. Sometimes we have to look past just what we're seeing physically and know there's some inner things that could be going on that's causing this person to have that type of pain. Important caregiver responsibilities: observe and report the pain, observe for side effects of medications, administering non-drug therapies, which would be the things like the music, the reassurance, like Stacia was saying, talking with them, just kind of giving them that additional encouragement, and provide emotional support to both the patient and families. Thank you all.